Hi guys, we shall now be talking about neuromyelitis optica spectrum disorder. When I was at your age, I used to read about this disease as Devick's disease. It's a autoimmune disorder, so gender-wise, obviously, female patients are more commonly involved as compared to male patients. The gender ratio in this condition hovers around something in the range of 3:1. In this autoimmunity, the main target is damage to the astrocytes. So the pathologist will use the word astrocytopathy to describe it. And when I say autoimmune disorder, it obviously will be having a target. So the target in this condition is the food processes of the astrocytes. You very well know that the food processes of the astrocytes are responsible for formation of blood-brain barrier, and any kind of damage to the blood-brain barrier will play havoc with the CNS with respect to myriad manifestations that can develop in the patient, because once that happens, the repair system of the body will also come into picture. So the damage in the brain in this condition can be substantial. It could be damaging especially the white matter area of the optic nerve, white matter of the spinal cord. So the manifestations will revolve from blindness in a person, which could be sudden onset, it could be bilateral blindness, there could be tingling sensation in the arms, and a transverse myelitis like a presentation, which could be like a monoplegia or a paraplegia or even a quadriplegia. And most of these patients, if they develop a cervical myelitis, then the diaphragm would be paralyzed. So one of the reasons for death in patients on neuromyelitis optica is respiratory paralysis. Now the food process of the astrocytes are having a special channel which is the main target of this disease, and this target is called as aquaporin 4. And now medical science is able to measure this antibody. So we actually can not only measure the antibody but demonstrate the titers of it. That is, anti-aquaporin 4 antibody is the main reason behind the development of the disease. And if you ever read a question that begins with saying a female patient, blindness, spinal cord involvement, and then says anti-aquaporin 4 antibody, the diagnosis is straightforward: NMOSD, that is neuromyelitis optica spectrum disorder. Due to damage to this aquaporin 4, the end result is the blood-brain barrier in the patient has been compromised. The repair mechanism of the brain will come into practice, so they could obviously be very characteristic MRI findings which would be present in this patient. Let us now look at what are the core clinical findings which are encountered, because most of the time in the MCQs they have asked regarding the diagnostic features of the disease, where the first two features are very standard and easy to retain. The first feature of this patient is optic neuritis. You will read about optic neuritis as a primary presentation of even multiple sclerosis, but in multiple sclerosis most of the time the optic neuritis is gradual onset in development, that there is a gradual decrease in visual acuity of the patient. In neuromyelitis optica, mostly the optic neuritis can be sudden in onset and will obviously be fast progressing. So sudden onset blindness is the initial presentation that can be given for this particular patient, and will also be bilateral, whereas in multiple sclerosis it is usually unilateral, or even if it is bilateral it is asymmetrical progression with the visual acuity in both eyes, but here the person has suddenly gone blind. The second feature of this person is transverse myelitis, which will be written as LETM in the MCQ. LETM stands for longitudinally extensive transverse myelitis. The definition of the word longitudinally extensive transverse myelitis would mean that more than 3 consecutive segments of the spinal cord would be involved. It could be cervical area consecutively like C3, C4, C5. It could be thoracic spine. It could be combination cervical and thoracic spine. And as I highlighted, in this condition, if the cervical spine is involved, then respiratory insufficiency can definitely occur in the patient. So two main hallmarks of this condition are optic neuritis and LETM, longitudinally extensive transverse myelitis. How the transverse myelitis will present initially could be simply something as simple as that the person might say that I feel as if somebody is poking me with a pin all over my body or half side my body, or maybe on both the limbs, or maybe one arm. So pin and needle sensation, unpleasant pin and needle sensation, painful sensation that might awaken the person from sleep is the initial presentation. And later on, the myelitis component can be so bad that the person might be having no feeling in the legs. Person might say that I feel I have woody legs, because there might be spasticity, and then there might be a frank inability to walk. So ambulation issues will definitely be present in patients of neuromyelitis optica, and everything will develop very fast as compared to multiple sclerosis, which has a rather slower course. Now, the third feature of this condition is very peculiar in a sense that not only does this disease damage the optic nerve in the spinal cord, but can even contribute to lesions in the vomiting center, that is area postrema. So the word that will be written to describe this manifestation could only be in the form of nausea, vomiting, hiccups in a patient, but protracted vomiting. And for this, no other cause would be thought. Like, you initially might think that because it's a CNS case, the person could be having raised ascites, but there would be no finding of raised ascites in the form of a papilledema. There would be no sixth nerve palsy, which is a false localizing sign found in raised ascites, bradycardia, hypertension, Cushing reflex, Bytes breathing, Cheyne-Stokes breathing. All the features of raised ascites that I have basically spoken about would not be found in this case, because this is not raised ascites. It is direct damage to the vomiting center. There is a demyelination, there is a damage to the blood-brain barrier related to the vomiting center. So area postrema syndrome is a very classical terminology to describe this. Then there could be endocrinopathy in a patient. Now look how surprising he says endocrinopathy. This is because of the fact that hypothalamus is related to we feeling hungry, and then when you eat food you feel satisfied also, and you have a satiety center in the hypothalamus. So hypothalamus tells us when to start eating food and when to stop eating food, because we have a hunger center, we have a satiety center. In this condition, the hypothalamus of the person can be damaged, and the person can be having extreme anorexia, avoidance of food with severe wasting, that is called as diencephalic syndrome. Diencephalic syndrome occurs because of lesions in the hypothalamus of this particular patient. It is characterized by a progressive anorexia in the patient, which might you think that this person is having maybe a cancer, because cancer can also be having anorexia with a significant weight loss. But when you combine this feature with the other features, neurological ones like optic neuritis and transverse myelitis, then you can figure out that this person is having a disease process which is having manifestations spread all over the brain parenchyma, including the hypothalamus damage, that is diencephalic syndrome. Another feature that is described in this patient is development of sudden onset narcolepsy, which means that there is an increased daytime sleepiness in the patient. So imagine what has happened to the patient. Just like that, one, the person cannot see properly, the person cannot walk properly, he is vomiting all the time, he does not feel like eating anything, and is also having an increased daytime sleepiness. I repeat the features again. Young female presents with sudden onset blindness, can't walk properly or walks on wobbly legs. She feels as if she will fall. She can't even go to bathroom because she can't see the pathway going to the bathroom. Maybe she might be able to feel her way across, but because of the wobbly legs, she fell down. And then she's puking all over, and she can't even get up and go to the bathroom by herself to vomit, because this is regularly occurring. No raised ascites present. Then in these patients, the person does not eat anything, so the weight is decreasing, and the person is sleeping most part of the day, that is increased daytime sleepiness, that is narcolepsy. So you can understand the extensive manifestations of these patients. The fourth clinical feature of this patient is called as acute brainstem syndrome. Now this is very surprising, because normally when we read about transverse myelitis, we just read about spinal cord involvement, but here I'm talking about a transverse myelitis patient having a brainstem involvement also, and in the brainstem there are cranial nerves. So there's a possibility that in this same patient he might describe a third nerve palsy and development of hemiplegia. Why? Because in the midbrain of the patient, the crus cerebri could be affected in this case, and crus cerebri is related to the corticospinal pathway. So damage to crus cerebri, adjacent to which the oculomotor nerve is passing, can result in third nerve palsy with a contralateral hemiplegia. See, the features which are described for Weber syndrome can also be developing in the patient, again because of damage to the blood-brain barrier related to the crus cerebri area. Do not be surprised if he in the same question also describes features related to cortical stroke in the patient, that is cerebral syndrome. The reason why we are discussing this topic is because there is combination of eye involvement, spinal cord involvement, brainstem involvement, and cortical involvement, I mean cerebral involvement in the patient, could be contributing to development of seizures and encephalopathy in a patient. So therefore the clinical presentation of this disease can be really very confusing, because so many areas of the brain are getting involved. Earlier, we could not identify a lot of these patients. A lot of these patients were misdiagnosed as maybe having only a stroke or maybe having a development of acute disseminated encephalomyelitis. But now we have been able to classify the disease as neuromyelitis optica spectrum disease because so many manifestations can be seen in a patient simultaneously. So, for diagnosis of NMO, you need any of these six manifestations that I have mentioned. So, any one core clinical feature should be present in the patient. And along with this, should also be present the name of the antibody, which is the villain behind all of this. Anti-aquaporin 4 antibody, which will cause astrocytopathy, damage to the blood-brain barrier in extensive areas of the brain. So, if we can demonstrate these at least one clinical feature and aquaporin 4 antibody, the diagnosis is made. Now, a lot of time in these patients, anti-aquaporin 4 antibody is not detectable. In those circumstances, you need at least two core clinical features to be demonstrated in the patient. Along with this, then there should be evidence of MRI findings in the patient, very characteristic ones, which I'll just describe before you. And these two clinical features should not be developing simultaneously. Like, if two features are developing simultaneously, like, continuous vomiting and then cortical manifestations like seizures or encephalopathy, I might think person might be having stroke. So here he will always write the word dissemination over space. What you understand by the word dissemination over space is that clinical features are not going to occur simultaneously in the patient but will occur over a couple of days. Like I described, like female, she cannot see properly with one eye. Tomorrow the other eye vision is also gone, and maybe by 4th or the 5th day she is walking on wobbly legs. She feels she will fall, and by the 7th day she can't move her both legs. There is a paraplegia in the patient. She's having pin and needle sensation in her legs. So those are features of transverse myelitis that has developed in the patient, along with obviously MRI findings, which would be usually a gadolinium enhanced MRI via gadolinium MRI, because I want to demonstrate the damage to blood-brain barrier. The findings on MRI of this patient are mainly with respect to the optic nerve. So he says more than half the length of the optic nerve inflammation should definitely be demonstrated. Or he will say longitudinally extensive transverse myelitis. LETM is longitudinally extensive transverse myelitis, which is spreading over more than 3 segments. In fact, I'll just show you an image for longitudinally extensive transverse myelitis. Like you can see here in the patient in the T1 images, you can notice a hyperintense signal which is found in the spinal cord of the patient, and that is present over multiple areas. So we will call it a longitudinal extensive transverse myelitis developing in a patient. And then obviously on routine sections also there can be presence of cloud-like lesions. I'll repeat the word, not Dawson fingers. I did not say Dawson. Dawson finger is periventricular lesions that I have described in multiple sclerosis. Here I'm saying cloud, CLOUD, cloud-like lesions developing in the brain parenchyma of the patient. And then the surprising thing is these clouds might appear and disappear disappear from here and appear in another area. So when you read about cloud-like lesions in the brain parenchyma, no Dawson fingers present in a patient, and presence of lesions in the spinal cord of the patient spread over more than 3 segments, then that goes in favor of Davick's disease or neuromyelitis optica spectrum disorder in the patient. So more than half the length of the optic nerve or LETM, longitudinal extensive transverse myelitis, has to be demonstrated. Damage to area postrema, if visualized, is great. That will explain that this person is having recurrent vomiting, not because of any raised ascity, but is mainly because of the irritation to the vomiting center. Then I mentioned about cloud appearances with respect to MRI. And another feature to be remembered is written as periependymal brain lesions. So if you read any of this vocabulary, that obviously goes in favor of diagnosis of NMOSD. Coming to the treatment of neuromyelitis optica, the mainstay of therapy would be steroids only, that is methylprednisolone. Do not answer beta interferon or glatiramer for this patient, because beta interferon and glatiramer are disease modifying therapy for multiple sclerosis. But here we talk about NMO, so the DOC for the patient is methylprednisolone. If the person is having no response or poor response, or the treatment with methylprednisolone is failing, then we also have a backup of a technique by the name of plasmapheresis. Here we will remove the dangerous antibody from the circulation of the patient. So plasmapheresis effectively would look like hemodialysis only, but you can see these huge plasma bags, jumbo bags present, where we clean the patient's plasma of the toxin and send patient's plasma back into his body. So plasmapheresis that is done in this patient is usually done for 7 consecutive days. It is done on daily basis. The volume of plasmapheresis done is 1.5 times the plasma volume, and plasmapheresis is also used in management of patients of hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and today we have added NMO, that is neuromyelitis optica / the older name Devick's disease, to this list as well. If he says, how would you prevent development of future episodes of blindness in the patient, then the mainstay of treatment for prevention is mycophenolate. I repeat my statement, do not answer beta interferon or glatiramer, which are drugs used for management of multiple sclerosis and redevelopment of symptoms. We use them, call them as disease modifying treatment. If glatiramer is used in this condition, if beta interferon is used in this condition, it will cause worsening of these patients. So all the disease modifying drugs which have been taught in multiple sclerosis topic, they are contraindicated in NMO. Instead of mycophenolate, another strategy which can be used in especially poor patients in our country is a combination of prednisolone with azathioprine. The prognosis of this condition is bad, recurrent attacks will occur, and death of this person can occur due to respiratory insufficiency. This is mainly related to cervical myelitis, which could be occurring in the patient. So respiratory illness or respiratory paralysis is the reason for development. This is a stubborn disease, I would say, difficult to manage. The antibody, the villain behind this is anti-aquaporin 4 antibody. So first you do a anti-aquaporin 4 antibody titer, you don't find it, you do a MRI involving MRI of the spine, MRI of the brain, so that you can pick up the cloud-like lesions in the brain, extensive lesions in the spinal cord. But if anti-aquaporin 4 is also negative, MRI spine is also normal, MRI brain is also normal, and you're looking for what is the reason, then there's another antibody to be remembered for this condition, which is by the name of anti-MOG. Now MOG, as the name suggests, M stands for myelin oligodendrocyte glycoprotein antibody. This is again a targeted antibody which is responsible for development of some patients of NMO. Where would you answer this antibody? In patients who are anti-aquaporin 4 negative neuromyelitis optica. Reminding you once again, the dictum of diagnosis of this patient is either you should have one clinical feature out of the 6 that I've explained to you. The 6 clinical features we can revise once again could be eye involvement, spinal cord involvement, then could be damage to the vomiting center, so person will puke again and again. Endocrinopathy manifestation like damage to hypothalamus, so he person will not eat anything. Weight loss, that is diencephalic syndrome, or excessive sleepiness, that is narcolepsy. And then 2 things are very peculiar. They could mention stroke like symptoms in the patient involving the brainstem, so you call it acute brainstem syndrome because brainstem is cranial nerve palsy, so 3rd nerve, 6th nerve, anything can be written. And if it is cerebral syndrome, then seizures and encephalopathy manifestation can be given. So 5 and 6, if given in a question, they are mainly to distract you. How would you pick it up from stroke? Stroke is catastrophic. It is sudden, right? Everything would occur together. But in this condition, there is dissemination of symptoms over space. That is, if one symptom will occur today, then another one might occur after 2 weeks or maybe after 6 weeks. So this week the person went blind, then there was problem in the legs of the patient, pins and needle, wobbly legs, that person can't walk. So gradually the manifestations will occur in the patient and MRI will pick it up. If none of these investigations are positive, then obviously an anti-MOG antibody is to be also remembered for this condition. And just to finish this topic, I want you to remember that this antibody has also been demonstrated in pediatric cases of ADEM, that is acute disseminated encephalomyelitis. The clinical correlation of acute disseminated encephalomyelitis can be that in earlier times we used to use mouse brain derived rabies vaccine. You see, now we have Rabipur and Virorab, that are human diploid cell vaccines, and Viro cell derived vaccines. But earlier in government supply they used to be having this mouse brain derived rabies vaccine, and I've seen a case in my career when I was at your age where a person was given a rabies vaccine in a government hospital, and the person developed acute disseminated encephalomyelitis. The person did not have rabies. The person did not develop rabies. He was given because of a dog just had an unprovoked bite, and this person was given the mouse brain derived vaccine, and the patient then developed features of encephalomyelitis, which means obviously that he went into encephalopathy plus was having brisk reflexes, spinal cord manifestations also. So acute disseminated encephalomyelitis, which can be associated with vaccines, is also related to an antibody by the name of myelin oligodendrocyte glycoprotein, which obviously explains, you see, the target of antibody which will affect oligodendrocytes, astrocytes in the brain, because they are the basic infrastructure of the brain. You hamper the infrastructure, the entire system will fall apart. So this disease has been very frequently asked in AIMS exam and couple of central exams. That is why I've spoken about it. So do remember the table that I mentioned. If you get an orientation for this, then you are bang on spot for remembering this particular disorder, which is very characteristically referred as a astrocytopathy with a special name anti-aquaporin 4 antibody, which is the target of this disease, and the blood-brain barrier damage explains the remaining manifestations of the patient. So keep working, keep studying, keep hammering, and I'm sure you will come out with flying colors. Thank you so much for listening.